All right, good morning and welcome to our morning plenary session, the impact of COVID-19 on behavioral health. Once again, my name is Kurt Hooks. I have the pleasure of hosting today's panel. A few housekeeping reminders. Please keep your microphones muted. The last 10 minutes of the session today will be used for questions. So you can feel free at any point during the presentation to enter your questions in the QA box at any time during the session. As time allows, I will ask our presenters to respond to the questions at the end. So let's go ahead and get started with the introductions. First, we have Rebecca Chickey, who is the Senior Director of Behavioral Health Services for the American Hospital Association. In this role, Rebecca serves as the AHA Field Engagement Strategic Behavioral Health Expert. With 30 plus years of experience in healthcare, Rebecca has expertise in shaping behavioral health strategy and health policy. She serves as a subject matter expert in behavioral health to the largest membership organization for US hospitals and health systems. Rebecca also leads the work to advance the AHA board initiative to help the field transform the delivery of behavioral health services through the integration of physical and behavioral health treatment and collaborative community partnerships, as well as address workforce shortages, diminish behavioral health stigma, and reduce deaths of despair. She has undergraduate degrees in business and psychology from Rhodes College and a master's degree in public administration and mental health care from the University of Memphis. Once again, welcome, Rebecca, and thank you. And then we have Kana, Enomoto, I believe I'm pronouncing that correctly. Apologies if not, who is the senior knowledge expert at McKinsey and Company. Kana is a nationally recognized expert in mental health, substance use, social determinants of health, and trauma. She is a consultant at McKinsey and Company and co-director of the Center for Societal Benefit through Healthcare. Kana has more than 20 years of experience as a federal executive in behavioral health policy, data, programs, and practice improvement. Prior to joining McKinsey, Kana was acting administrator of the Substance Abuse and Mental Health Services Administration, SAMHSA. She has also served as senior advisor to U.S. Surgeon General Vice Admiral Jerome Adams. Kana earned her bachelor's degree in psychology and master's degree in clinical psychology from the University of California, Los Angeles, and is a graduate of Harvard University's Kennedy School of Government, Senior Managers, and Government Program. Some fantastic guests, a great session ahead. So at this time, I will turn the session over to Ms. Chickey and Ms. Enomoto. Thank you.
Thank you so much, Kurt. It is an honor to be here with you, although obviously we all wish we could be face-to-face, but it just shows how we persevere in this time of an incredibly tragic pandemic. But that's not what we're here to talk about specifically. Rather, we're here to talk about the impact of this pandemic on behavioral health. So let's just level set it. Next slide, please. And give time for the slides to, okay. So I realize that if you are dialed into this presentation today, more than likely you are already aware of the reality of some of the statistics of the impact on the mental health and well-being of all Americans that COVID has had. Just wanted to add in some, rather than what you've heard on the media, some of the statistics that have come from the CDC. In 1 year in, so this is before the Delta variant has had the traumatic impact that it has and is having currently. Just 1 year in, 31% of Americans reported symptoms of anxiety or depression, 26% reported stress, and 11% reported serious thoughts of suicide in the past 30 days. That's almost double the rates before the pandemic. Couple of other statistics that are not on this slide, but just to, again, to level set the severity of this. The Wellbeing Trust came out with an estimation that there would be 75,000 more deaths in terms of suicides, but specifically because of COVID. That's their estimate on top of the 70,000 overdoses that the CDC reported, as well as the 50,000 suicides. So the magnitude that this is having and the trauma of the length of this is significant. To accompany this, the reality is that there are not enough in behavioral health providers across the board. When you think about what has happened to state-based and operated inpatient psychiatric beds since I think it's from 1955 to 2016, 97% of those beds across the country have closed. So I know that Virginia is not immune to this. In fact, if you look at the quote at the bottom of this slide, you well know more than I the impact of the closure of 5 of the state's 8 adult mental health hospitals to new patients or individuals. Next slide, please. This slide should probably be titled Misery Loves Company, but I just wanted you to know that Virginia is not alone. This literally is from a Google search of, what's the impact of COVID on inpatient psychiatric beds. And as you can see, it ranges from Portland, Oregon to Boston, to Montana in Bozeman, to North Carolina, much closer to you. The impact is not just adults. As you can see from the NPR article, children and adolescents are just struggling. There was a shortage of child and adolescent psychologists and psychiatrists even before the pandemic, as well as beds. And so this is where we're seeing just a huge tragedy in terms of access to services. Next slide, please. So what are some of the solutions? And Kurt mentioned this in my introduction. These are the 3, and I'll be honest, they're really 4, but everybody likes things in 3s. But these are the 3 areas that we are focusing our resources on. 1, if we've got the reality that the pipeline is what it is right now, what can we do right now to be able to begin to alleviate that? And we truly believe, and we are advised by an 18-member National Advisory Council of both clinical and administrative leaders of our hospitals and health systems across the country. We believe that the integration of physical and behavioral health, not just in primary care, that is going to be key, but as the American Hospital Association, we need to be a leader in providing resources to our members on the why, should you integrate physical and behavioral health? And I'll talk more about that in a few minutes. The why of it, why should you integrate in an inpatient setting? And why should you integrate in an emergency department setting? And what are the best practices in those areas? The same exists for primary care, but thankfully that is a trend that is happening, as do many things, moving from the West Coast to the East. But primary care, and when I say primary care, I don't just mean family practice and internal medicine. I mean pediatricians and OBGYNs and other clinicians like that, where you may be seeking primary care. That is happening across the country, but hospitals can also play a vital role in encouraging and stimulating that. So integration is one of the first solutions, but they are interconnected. Hospitals cannot do this on their own. And I'm going to give you some examples in a minute here of how hospitals have been successful in creating a continuum of care, getting outside the 4 walls of their hospitals and working together to collaborate to improve access to that care. Finally, the one that is really 2, reducing stigma and deaths of despair. And we specifically called out deaths of despair to include not only suicides, but overdoses, and additionally, something that doesn't get as much attention, but our clinicians in our hospital see it every day, individuals dying from organ failure, often due to substance misuse. So think cirrhosis of the liver. Next slide, please. So the why, the how, as I talked about, one of the things that AHA is stepping forward and out on, as thankfully is the AMA and another group of national clinical associations. Why should you integrate physical and behavioral health? At the heart of it, it improves outcomes, it reduces the total cost of care, and it improves the patient experience. And something that's not called out here, it often improves the clinician's experience of treating the individual. I've called out a few best practices here, and I will say to you, these best practices and more statistics, and I can share this with Jennifer post, or you can Google it, it's publicly available, are called out and described in a little bit more depth in our 2019 Trend Watch on behavioral health. So that's where these three examples are coming from. Just look at this. At Intermountain, when they really truly integrated in primary care, they reduced emergency room visits by 18%. And they improved the physical health of their patients. Some of you have heard the statistic that individuals with severe mental illness, so think schizophrenia, think bipolar disorder, they die somewhere between 17 and 25 years earlier. When we talk about healthcare inequities, that is a huge inequity. And one of the reasons that people often think, oh, that's probably because of suicides. No, it is often their death is caused by the lack of attention to their physical health comorbidities. So the ability to have people adhere to their diabetes protocols increased by 25% is hugely significant. Reducing the total cost of care. As you can see here, Cherokee Health System, which is in the eastern part of my home state of Tennessee, reduced their emergency room visits, their hospital care, and reduced their total cost of caring for those patients through the integration program by 22%. And then enhancing the patient experience. Montefiore Medical Center in the Bronx created a mobile app that they placed on smartphones for individuals who have severe mental illness and chronic physical comorbidities. And as you can see, for individuals with that complicated physical and mental health history, for them to say that they felt more connected, 72% felt more connected to the team and expressed overall satisfaction, that's huge. I wish I could do something, in our own organization or elsewhere, anywhere, wave a magic wand and have an improvement in terms of overall satisfaction with one tool of 72%. This same tool also allowed their case managers to take on 20 more patients effectively. Next slide, please. I'm loving the questions coming in. We will get to them, promise. Community partnerships. So here, the story that I want to tell really echo the fact that hospitals can't do it all alone. Many of our hospitals don't provide any sort of psychiatric or substance use disorder services. There's a series of podcasts that are available on AHA's Advancing Health channel featuring Tidelands in South Carolina. They do not have an inpatient psychiatric program, but through community partnerships, they have been able to, when an individual comes into their emergency room, be able to provide them and connect them with care. The one story I want to show here really quickly is Tampa Bay Thrives. These case studies are all publicly available. They're Google search. The reason you don't see the profile kind of layout of Spectrum is it's going to come out later this month, early next. But Tampa Bay Thrives. This is something where they brought in McKinsey and pulled together 4 CEOs from competitive hospitals. One is an HCA hospital, one is a network of hospitals that is called Baycare. Another is the Safety Net Hospital, Tampa General, and then an Advent Health Hospital. They began pre-COVID to pull together a huge group of community providers, everyone that you could think of, to say we need to work together to elevate and improve the access to behavioral health services and the prevention that is out there and easily, readily available. They now, thankfully, because they had started talking pre-COVID, one of the, in addition to launching a helpline for the region, and in addition to improving access to care, it had unanticipated consequences because the CEOs knew each other when COVID hit, and you know it's hitting Florida hard. They continued their Monday huddles. They shared PPE. They balanced patient distribution. They touched base with each other to make sure if there was anything that they could do together to improve the delivery of care. And they said it's because they created this community partnership ahead of time and they knew each other that it allowed them. They've also coordinated the distribution of the vaccinations. So not only is working together in behavioral health good for behavioral health patients, but it can have positive other implications. Next slide, please. So even if we improve access to care, there's still stigma, right? And it is still so prevalent. I'm the mother of 2 millennials. And thankfully, they and their cohorts coming behind them, the stigma is not as great, but it still does exist. So one of the things that we have launched, and again, this is publicly available, you can download it, you can share it, are a series of posters just to help people think, have access to what should I say? What is appropriate? How do I address this? You can see here, one is using people first language, one is culturally and racially aware, one is on substance use disorders, and one is on just the perception of individuals with mental illness. Did you know it's as common as brown eyes? At any rate, please feel free to download. The next 2 that are in queue to be developed behind this is one on suicide and one on post-traumatic stress disorder. So we've even had the mayor's office from Baton Rouge contact us to find out if they could share these posters with their healthier communities. And we said, sure, take it, spread it, all the better. So please do the same. Next, and I think the last slide, yes. So the stigma is great for, young and old, all walks of life. All cultures, but it's particularly tough for our workforce. So what you see here is something that was originally developed by Providence Health in March, April of last year, when Washington, Oregon, and California were just in the throes of COVID. They have given us the right to take their code, and we are in the midst right now. We've written the code to make it more easily available to all our hospitals and health systems. We're in the process of vetting through our advisory committee that I mentioned earlier, all the publicly available free resources that are out there that might be appropriate if you clicked on mild, moderate, or severe. So this is not meant to be a clinical tool. When we roll it out, hopefully in December, it will be available. Organizations can put it on their intranet so that, and this is what Providence does, when people log in the morning, they see this. It's also a destigmatizing tool. It's a way to say, how are you today? Before you go care for other people, how are you? So the initial rollout will be just publicly available resources, because we want this to be something that our critical access hospitals that are not part of a health system can just use as a tool and run with it. Eventually, if we can get funding and have the bandwidth as well, we would like to customize the coding so that people can plug in their own EAP. Maybe they've contracted, and this is not a promo for it, but maybe they've contracted to provide Silver Cloud to their organizations or any others. So this is something that watch for it. It will be coming out in December. We're vetting the resources now, and we're also asking our committee members to let us know what is missing. So with that, I will take the time now to turn it over to Kana. One of the key link messages, I think, between both of ours is digital technology has helped improve access to care. So take it away, Kana.
Great. Thank you so much, Rebecca. I really appreciate everything that AHA is doing in the space and the leadership that you've shown over the years. And thank you too for to VHHA and Kurt and Jennifer, who has done so much to wrangle us and get us here today for this great conversation. As Kurt mentioned, I'm Kana Enomoto. I used to be the head of SAMHSA, and now I am a co-director of the Center for Societal Benefit through Healthcare at McKinsey and Company, where I have the privilege of trying to bring the strengths of our firm and to address some under-resourced areas of healthcare. So primarily that's mental health, substance use, social determinants, rural health, and maternal health. And one of our big focus areas, and of course, over the last year and a half, has been the impact of COVID on behavioral health, and in particular, service utilization and access to care. Early on, we had also done some projections in terms of impact, and I don't think anyone had projected the level of kind of depression and anxiety symptoms that would get picked up through the CDC data and other sources that Rebecca referenced. But it's been an interaction between efforts that our healthcare system needed to make to increase access for COVID care, and at the same time providing access to behavioral health services through tele and other hybrid models. So if we want to go ahead and go to the first slide, Rebecca gave us such a great overview. I'm going to dive straight into some sort of national and Virginia specific data. And if anyone is interested in accessing these data, they are on our Open Access Center for Societal Benefit dashboard that I just put the link in the chat. But here you can see that there's pretty significant variation. The blue coloring is the level of primary care visits, and the dots are the size of the increase in BH visits. And there has been a drop in access to behavioral health care if looking at claims data across Medicaid, Medicare, and commercial insurance. But I think it's important to put the drop in behavioral health access in context of primary care. I'll show you in a bit general medicine, because nationally, we've seen a significant drop in primary care, which has just sort of recovered in the spring of this year, whereas overarching behavioral health visits recovered. It didn't drop as far as we know. There's been so much tele-BH, but also recovered more quickly and came up to pre-pandemic levels as early as last summer and fall. And then now are far exceeding pre-pandemic levels. However, that's nationally. And in Virginia, you see that we're still actually below pre-pandemic levels. And so that's interesting, I think, given some of, perhaps some of the redirecting of beds or units to non-BH care has had some impact on that, because we see still some substantial uptake of telehealth resources. So if we go to the next slide. Here, this is looking at the uptake on tele-BH. People frequently ask, do we think that telehealth is here to stay or not? If for behavioral health, we see that we had the rapid peak, obviously, last spring, but it has for for behavioral health, it has sustained at a fairly steady rate. And you see at the US, we're at about 31% of telehealth BH visits are by tele, and in Virginia it's about 26%. So it's and has held steady for the last year plus. Overall, when we look at psychotherapy visits, so this is not ED, IP, or PHP, detox, or drug screening. These are the codes for psychotherapy. And in Virginia, so while we saw overall BH access was still below pre-pandemic, your psychotherapy visits are, pretty through the roof, right? Like 24% increase in Virginia, which is sort of it's actually above the national level of increase in psychotherapy. So, it's interesting variation to see and understand where it's happening. So, if you're representing the hospitals, you may be still seeing a dip, but on the OP side, we're seeing some significant increases. If we go to the next slide, this is the psychiatry claims. So we see general medicine, generally we're sort of on par. Virginia and the US in general are on par in terms of general medicine claims that are going by tele, which is around 7%, whereas psychiatry claims are around 50%. So again, that sustained shift, which, I don't think we have strong reason to believe that this is going to drop substantially, where it's, you saw the peak for general medicine and then a rapid drop down to what seems to be a sustained rate, which is not that different from the rate. It's different. It's higher than the pre-pandemic rate, but not as substantially different as our behavioral health one. And then going to the next page. Oh, I'm sorry, if we could go back to that previous page. Another piece that I wanted to point out here was that we are also seeing differential patterns in the uptake of telepsychiatry. So, there's a few states that have, Michigan, you can see here, New Mexico, you see they have had a pretty, and then the states in the Northeast, much greater adoption of that telepsychiatry and still there's a lot of room to improve in our, our rural and frontier states. So I think there's still opportunity, but you see Virginia has had a pretty strong uptake on both sides. Okay, so then we go to the next page. And here, this is just to put it in context, where behavioral health is relative to other specialties. Where, some of this makes perfect sense, and here is my last slide, which is looking at the crisis care continuums. I think we've talked about how else, what is other potential contributors to reducing overcrowding in ERs and long waits for beds. I think for those of you who don't already know, that in July 2022, we expect 988 to go live as the national mental health and suicide crisis line, where all calls to 988 will be routed to the National Suicide Prevention Lifeline. This is a FCC decision from October of last year. And we anticipate that there's also been quite a bit of movement, a set aside within the mental health block grant, new Medicaid waiver options in terms of funding for mobile crisis teams. And so we think that with this, there's going to be a strong effort across states to build out, and you probably are already doing this or seeing this, to build out that crisis care continuum, which I have outlined here. You have the crisis care continuum to the left side, which is really that sort of behavioral health, public health point of view. And then you have EDs in the middle, or not in the middle, but it's really the general health response, and then sort of moving over to the right side on a criminal justice response. And what we hope to see with the building out of the continuum, substantial reduction in reliance on EDs, police response, and so forth. And then we know that you see about a 60-70% reduction in the number of people who actually get admitted to IP when you have that build out of the full crisis care continuum. So exciting to see how that plays out over the next 8 to 10 months, and would be really excited to have the conversation about what that looks like here in Virginia. With that, I will wrap up and open up for questions.
All right, thank you so much again to both of our presenters, Ms. Chickey and Ms. Enomoto. Just staggering statistics. I wanted to I took some notes on some questions. We won't have time to get through all of them. But with that said, I did want to just clarify one, because it came up several times. There will be access to the presentations following the session and the summit today. One question came up in terms of best practices in regards to integration. So we talked about primary care settings and emergency departments, some other settings. Is there a sample or maybe a little bit of nuts and bolts about what that actually looks like and the stakeholders involved, and anything you might most be germane to that sort of a deeper level understanding of that?
I wish the simple answer was yes, but unfortunately it is not. I pointed out the 2019 Trend Watch, and the center of that Trend Watch. Again, it was 2019, so it's already 2 years old, but those 2 years have been unique, to say the least. That is a good spot to start in terms of the evidence-based research that is out there. I can add a couple of things that I also think, and it relates also to one of the other questions I was scanning in the chat, to around the violence. What does integration have to do with violence? One of the ones that I would strongly encourage you to look at is Yale's Behavioral Intervention Team, BIT. So they started, there was colloquially, I'll tell a little story here. The behavioral health leaders at Yale New Haven said, we really want to get ahead of some of the psychiatric and substance use disorders. So they approached some of their colleagues on their med-surg floors and said, hey, can we work with you to screen all of your admissions? And so they started small. I think they started with 1 or 2 units. 1 unit was medical, 1 unit was surgical. And please don't hold me to all the specific details. This is the essence of the story I'm trying to get at. And what they've done now is there is a 3-person team. I think it's a psychiatrist, either a psychologist or an APN with behavioral health background, and a social worker, and they screen each of the patients. If the patient, let's say, is on a surgical floor because they're having open heart surgery the next day, they're nervous, they're anxious, they work alongside those frontline staff on the cardiology floor to help them provide settings, calm the patient down, and they train those frontline staff to do that. On the other end of the spectrum, let's say it's the 3rd DUI, and the individual is in for their 3rd surgeries because of the car crashes. They will work, then they work alongside the med-surg clinicians, the surgical clinicians in this case, so that when their, quote, physical health is ready, they're ready to be discharged, and then they're placed into a substance use disorder treatment, whatever level is appropriate. So I think that is a great way to start, and something you can start on 1 unit at a time. At least that's how Yale did it. And it decreased the violence because the staff knew how to better anticipate aggression and what to do about it. So that was the tie back to that question. Kana, your thoughts? Or
No, I think that was great.
All right, thank you. Great response there. Great question. And look forward to seeing some more resources that we can look at some evidence-based models. And another question that popped up here was in terms of demand upon, and we've seen this increase, the demand upon primary care services with scarcity of providers and behavioral health and overall providers and access, which was discussed in the presentation. Demographically, are we seeing any differential between the demands for adults versus minors and pediatrics?
Yeah, it's interesting. It's a great question because we've actually seen a significant drop in access to care for kids, both for primary care as well as BH care. So nationally, it looks like, and I just put this in the chat as well. I don't have the Virginia specific numbers. I don't know if it's possible to download the data and suss that out. But nationally, we're seeing about a 12% drop in 12.5% drop in primary care visits for youth, and a 10% drop in, or actually now we're at a 10% increase for youth on BH visits, although it's lower than the national number of about 17% increase. So I think parents, it looks like, are a little bit slower to want to bring their kids back to care for very obvious reasons, as well as, we know that for behavioral health, about 50% of kids that get behavioral health care start that care in school. And so with kids not being in person at school, that has dramatically reduced access to services. And at the same time, we've seen the big jumps in emergency department use, particularly among young girls, but among boys and girls, we're seeing about 30+% increase in ED utilization relative to other conditions. And that it actually breaks down to about 50% increase for girls in ED visits with suicidal ideation. So the lack of access to routine care on the pediatric side is manifesting itself in the increased need for emergent care.
And that's a great segue. Just very quickly, about a minute before transitioning into our next speaker, but you mentioned the ED portion as well. And in Virginia, we are, of course, having the crisis we're having, which is leading to a lot of boarding issues for care recipients with acute mental health needs. Are there any specific models maybe that you might want to share with the group and a link for ED holding a unit or some type of model that can effectively provide concurrent care while trying to find an opportunity for whatever outside care of the ED will look like for that individual?
Yeah, so I referenced earlier the crisis care continuum. SAMHSA released last year guidelines for community-based crisis care, and I think that's really where we've seen some success in Arizona, in Georgia, where you've really built out the 23-hour observation beds, the mobile crisis team, the crisis respite. So you just prevent the boarding by preventing people from getting into the ED in the first place, so that those who are in the ED are those who truly need ED, those who get referred to IP. It's not because we're trying to get them out of the ED, but because they truly need that inpatient level of care. And so I think that's probably where at the federal side we've seen a lot of investment going to building out the crisis now, CAHOOTS models and others to have differential response and increase access to non-hospital ED IP care.
And
so early intervention and prevention to get things escalated to the point where someone would actually need to go to the ED or as an alternative receiving facility versus an emergency department.
Yeah, it's not really early intervention. It's a different option.
Got it.
Right. So In Maryland, for example, if you have a juvenile, you call the in Montgomery County, you call the mobile crisis team. They can come to your house, but they still have to take your kid to the ED for medical clearance. So it really doesn't alleviate any burden. But if there were other options, then you would be able to get care outside of the ED that would still meet the level of crisis need that's there.
Some of our members or some of the hospitals and health systems, Hackensack Meridian being one, are now embedding behavioral health providers in their urgent care clinics so that can be another option. And what you mentioned about in California, Dr. Scott Zeller with the Psychiatric Emergency Services, that's another resource if you want to learn more about it, because that's the 23-hour observation. In California, they worked with their Medi-Cal program, which is what they call their Medicaid program, to actually make sure that 23-hour observation was covered with a new special code. So just a couple of other thoughts. More people, I'm getting more context recently about who's creating psychiatric urgent care centers or embedding it in their current services. So
we look forward to hearing more and integrating those efforts here in the Commonwealth as well. So thank you so much, both of you, again, for your presentation. Thank you, audience, for your thought-provoking questions and the conversation dialogue in the chat. I saw that. Very well-attended session. We do need to be time sensitive here, so we'll move forward with our next presenting partner. It's Eric. His name is Eric Grant. He's the chair and physician assistant program director at Randolph Macon College on their new behavioral health physician assistant preceptor program. And I will just say briefly, following Eric's presentation, we will have another sponsor spotlight, and then our first set of concurrent sessions will then begin at 11:40. So Eric, please take it away. Thank you.
Thank you, Kurt. My sound working okay for everyone? The nod will do. Sounds like it. So thank you for your time. I'll be very brief. I have 5 minutes to share some exciting news from Randolph-Macon College. We're located just north of Richmond, Virginia, and we are setting up a physician assistant training program. And the reason that's important here today is because physician assistants can be very close care partners in behavioral health situations. And we know that there are workforce challenges in retaining and recruiting folks into behavioral health spaces who are prescriptive and multi-talented skill providers. So we want to be part of that solution for you and your stakeholders. A quick overview of the program. Our first class will enter in 2023, pending accreditation, and our students will go to rotations in clinical sites beginning January 2024. They'll be master's degree trained graduates and licensed by the state medical board for practice. Our focus and our mission is on reducing gaps in health equity and care provision. And we know this takes many different shapes and forms, but part of our goal is to identify where these gaps are most severe in Richmond and the area, the Commonwealth and the region, and work with stakeholders, including those here today, to think about how we can best tune and recruit providers into those spaces who are the best solutions for what's needed. I heard a lot of neat information today from different folks and in the chat around how PCP integration is important and how PCPs are often the front door for this sort of referral pattern. So we do want to be very conscious in our curriculum of developing the right sorts of de-escalation, identification, and referral training, as well as basic level counseling skills that can help to be a layer of protection for our population as we encounter increased amounts of behavioral health challenges. The quick overview of the curriculum is that it's 2 years long. So this is an efficient, quick training model. It's a compressed and focused version of what typical medical school looks like. The first year is 12 months long and contains complete organ system overviews from cardiology to women's health, behavioral health, orthopedics, and all the typical content areas you think of. With our behavioral health focus, we'll be focusing on normal and abnormal psychology, as well as difficult patients, anger, violence, substance abuse, opioid crises, and all the other pertinent topics which are currently facing our population, preparing them for the knowledge base. In the second year, which is 12 months long, students will do 6-week rotations. Behavioral health is a required rotation, so we'll spend at least 6 weeks with students embedded in behavioral health training environments. These can be health departments, they can be inpatient, outpatient settings. And part of our ask today, if you're able, is to reach back out to us with any opportunities you may have for our future PA students to work with you in your settings and to be part of your workforce as a trainee and perhaps in the future as an employee. We would love to partner with you to do that. If you haven't had a lot of experience with PAs, I'm happy to provide a quick overview. And if you've worked with PAs already, thank you for doing that. We're very happy to be part of your help. So PAs can evaluate, we can provide medications and write prescriptions, we can perform procedures, manage and referral care. We often work in collaboration with a multidisciplinary team, and that's where we're very good. Our training includes understanding all the different layers of the health system and not overly specializing in our training. So we do know the breadth and depth of challenges and can identify lots of different problems and solve them. The areas we can work include substance abuse clinics, inpatient, outpatient psychiatry, counseling centers, and health departments, as well as the previously mentioned multidisciplinary groups. As someone mentioned earlier today, we often see that integrated healthcare system as the ones who are providing the most pertinent and on-time care for folks. Our psychologists and our other psychiatry providers are critically important, but a lot of times folks are entering the system through a different route and needing proper identification and having bandwidth to see those patients and properly spot what might be needed is where we come in. How can you help us? You didn't ask, but I'm happy to provide this information. Again, we need training opportunities. We know that if students who are interested in medicine spend time in an environment with mentors, they're more likely to stay and work in that environment. So we are looking for folks across the Commonwealth and beyond who are interested in becoming mentors and preceptors for our PA students. We know that this will increase recruitment and attention and passion for the field. And as we talked about in earlier slides today, that knowledge base is what's going to breed familiarity and then desire to work there. We know that our workforce challenges are coming, and we'd like to have as much help as we can provide in bolstering our workforce in Virginia. We hope and know that there are additional funds coming for expansions of behavioral healthcare opportunities, and we want to be at the forefront, at the front lines, helping take care of folks. So what will we offer in exchange? So we have set aside financial support for preceptors and organizations who wish to help us. We know that teaching and education takes time and resources, and we want to support you with that. We also want to partner with adjunct faculty appointments, Category 1 CME, or other meaningful things you might need for your practice and group. So we're very creative and looking forward to hearing what you might have in mind. My final slide is really a way you can reach out to us. So the first QR code on the left is a preceptor interest form. This won't ask for any critical information, and it won't be shared beyond us. What we're doing is asking for folks who are maybe interested in precepting students on a 6-week rotation or part of that to just give us some information so we can reach back out to you. We won't bind you to anything or sign you up for anything initially. We just would like to meet you and hear your ideas and talk about partnerships. The middle QR code is our PA program website. There you can see more about our mission, what we're up to, and our focus on health equity, gap, and diversity training. And on the right, that's my email address and cell phone. Happy to retrieve any calls or emails. And the lower one is Erica Klein. She's our Director of Clinical Education. So she'll be coordinating all those rotations for folks. Thank you again. I'm going to pause here for Kurt if he has any things to direct me towards or if anything else I'd need to provide. Thank you all so much for your attention and time.
Eric, thank you so much. Just across yourself and our other distinguished speakers, common theme is, again, cross-stakeholder integration, behavioral health integration throughout the continuum of care, and just some really, really interesting and shovel-ready is really kind of solutions. It's just a matter of kind of how we, as a Commonwealth, we want to go about. I know we have STEP VA and Project Bravo and a lot of other initiatives, but I think these are all fully aligned with what our goals are and what our needs are. So thank you all so much. I believe we next have a sponsor spotlight, and session will be ending. So thank you all.
After several years of research and meaningful conversation with physicians, PAs, and other healthcare partners, the Medical Society of Virginia identified several key reasons that clinicians do not seek help for their burnout. These include the fear of losing their medical license, potential loss of their job, and potential reputational damage that could affect their future path, as well as referrals from other physicians and facilities. We also realized that providers were not granted the same confidentiality and HIPAA protections that the rest of us enjoy. The Medical Society of Virginia knew that we needed to find a solution to these issues and provide a safe way for healthcare providers to get their services and take care of their mental health and well-being.
Physicians and our entire healthcare team have been extremely affected by the COVID-19 pandemic, and it has led to an increase in burnout and an increase in necessary providers leaving the profession. Healthcare workers dedicate so much of their time to helping others, and in order to ensure we keep these necessary providers in their profession, we need a solution that allows them to get confidential and truly useful mental health support. The MSV's Safe Haven program offers that.
Psychological safety is key when we're discussing mental health support and resources. If a physician, PA, nurse, or anyone else is concerned about their health information being shared with their employer, licensing body, or others, then they aren't going to feel truly comfortable seeking help. The Safe Haven program was specifically designed to offer such protections and this sense of psychological safety.
Between large patient loads, administrative work, and needing to give time to our loved ones, healthcare providers have limited time in a day. Mental health resources need to be accessible and available at any time. The MSV works hard to find a solution that can be truly useful.
Once we discovered a way to solve for these confidentiality concerns, the next step was to ensure that we could offer clinicians resources that can actually help them in their day-to-day life. So we knew we needed a solution that had customized services and could be accessed whenever they needed it, day or night. The Safe Haven resources are intended to support clinicians in all aspects of their life. Many programs offered by employers and regulatory boards do not give providers the needed opportunity to seek confidential and protected support for them and their families. The program was created to ensure physicians and other members of the healthcare team regularly consider their mental well-being, make self-care a priority, and can get the right services needed in the moment when they're needed.
As healthcare workers, we feel like we must always be strong for our patients, and many of us feel as if we are asking for help, we may look weak. But we are human, and we cannot pour from an empty cup or provide energy from an uncharged battery. Safe Haven ensures that we don't have to. Now is the time for physicians and other clinicians to take back control over their mental health and well-being. By purchasing a Safe Haven subscription, you are doing just that.
On July 1st, Magellan Complete Care is changing its name to Molina Complete Care. As a member of Molina, you'll work with the same people and see the same doctors. You don't have to change plans, and most importantly, you won't lose your benefits. For 40 years, Medicaid members across America have leaned on Molina to get the care they need. To learn more, go to mccofva.com. New name, same people, same commitment to the community. Now you can lean on Molina too.